Thank you for giving me the opportunity to speak today. I'm from the University of Alberta. I'm one of the general surgery residents. Today I'll be talking about our analysis of the MBSAQIP database using for surgical site infections. I have no conflicts of interest to disclose. So obesity is increasing. Obesity has tripled since 1975. It currently affects 1.9 billion people worldwide. And because of this, there's increasing use of bariatric surgery, as mentioned in the previous talk. And the two most commonly performed procedures are the laparoscopic Roux-en-Y gastric bypass and the laparoscopic sleeve gastrectomy. Although bariatric surgery is becoming safer and safer, there are still some complications that occur. And we'll be focusing on wound infections or surgical site infections after bariatric surgery. So what is the global burden of surgical site infections? So about 313 million people undergo surgery every year worldwide. And surgical site infections are the most common complication after surgery. The global cost is about $10 billion. And surgical site infections have been found to increase both length of stay as well as mortality. In bariatric surgery, surgical site infections, the rate ranges quite dramatically from 0.1 to 10%, depending on the study, the technique, and the actual procedure. So we decided to analyze the metabolic and bariatric surgery accreditation and quality improvement program database. This is a clinically rich database that collects metabolic and bariatric specific variables from 791 bariatric centers, captures approximately 95% of all bariatric procedures in the United States and Canada. Our objectives were to identify factors associated with incisional surgical site infection within 30 days of bariatric surgery, and to develop a clinically useful tool that predicts the probability of 30-day surgical site infection after either Roux-en-Y gastric bypass or sleeve gastrectomy. We combined the two available years, 2015 and 2016, of the database. We included only patients undergoing either sleeve gastrectomy or Roux-en-Y gastric bypass, as these are the two most common procedures. And we excluded anyone under the 18 years of age who have undergone previous bariatric surgery or foregut surgery, anyone flagged as an emergency surgery, and anyone with a skin infection prior to surgery. Our independent variables, we included patient demographics, perioperative factors such as operative time, procedure type, various comorbidities, as well as their functional status, their history, their albumin levels into our models. We defined incisional surgical site infection as either having a superficial infection, which involves the skin or subcutaneous tissue, or a deep incisional surgical site infection, which involves deep soft tissue. We excluded anyone with like an organ space infection, like an intra-abdominal infection. So we wanted to specifically look at the incisions. We performed multivariable logistic regression analysis to determine factors associated with 30-day incisional SSI using a purposeful selection algorithm. And then we created a predictive model. We used a forward selection algorithm. We used the 2015 year as the derivation cohort, and then used the 2016 years to validate the tool against. And we assessed for accuracy using the area under the receiver operating characteristic curve. So we had 196,000 patients undergo sleeve gastrectomy, 77,000 undergo Roux-en-Y gastric bypass. 1,291, or 0.47%, developed an incisional surgical site infection. The majority, 89%, were superficial, and the rest were deep. And we found a 4 times higher surgical site infection rate after Roux-en-Y gastric bypass, 1.04% versus 0.25%. This is likely due to kind of that increased oral gastric contamination after Roux-en-Y gastric bypass. On multivariable logistic regression, we found 11 factors that increased the risk of surgical site infection. The biggest ones were Roux-en-Y gastric bypass, which had a 3 times the odds ratio. Other big factors were chronic steroid or immunosuppressant use, diabetes, as well as female sex. This was adjusted for all the other comorbidities. And then this is our tool. We're calling it the BARIWOUND tool, which is a point system. So the highest points would be if you're getting Roux-en-Y gastric bypass, you get 5 points compared to sleeve gastrectomy. Chronic steroid or immunosuppressant use gives you 4 points. Other various factors give you 2 points, and things like diabetes, hypertension give you 1 point. And then operative time, you get 1 point per hour. Body mass index, 1 point every 10 kilograms per meter squared. And partial points are allowed. And with this, you get a kind of a cumulative score, and then this will stratify patients into low, moderate, high, or very high risk, which correlates with less than 1, 1 to 5%, or 5 to 10%, and then greater than 10% risk. It's quite rare to get someone this high because you pretty much need all of the scores to be positive. When we check the accuracy of our model, our area under the curve for the derivation and validation cohort were 0.74 and 0.73%, versus 0.73. So numbers closer to 1 makes a better model. Numbers close to 0.5 is pretty much like flipping a coin. So our model performs quite well. Like what they say 0.7 or higher is a relatively decent predictive model. So in conclusion, the risk of surgical site infection after bariatric surgery is quite low, 0.47%. However, some populations have a higher risk. One's higher BMI, certain procedures, like gastric bypass, diabetes, chronic immunosuppression. And this tool allows for stratification of low and high populations. We think that the BARIWOUND tool can allow for informed clinical decision making. Patients will know if they're at a higher risk. And this could allow for us to target preventative packages, kind of like the Cleveland Clinic technique with the wound protection, wound irrigation, wound packing, and loose approximation, to be targeted only at high-risk populations, just as a resource-saving measure. The biggest limitations of our study was that it lacked data on the use of prophylactic antibiotics, the severity of the surgical site infection, as well as how surgical site infections were treated, whether treated with antibiotics or just wound opening. Another major limitation is the lack of detail on the surgical technique, as the previous presentation demonstrated, like using a transoral technique really increases rates of infection. So we don't really know that. So we don't know if the gastric bypasses were done with a linear stapler or circular stapler. I'd like to thank the research team as well as the University of Alberta. Any questions?